first case is an example of that, where you see this 54-year-old female presenting with asymptomatic red-orange plaques on the bilateral shins. So you can see these plaques on the bilateral shins. And when we look at the biopsy here, let's make this straight here. So what we see is very even on low power, we see this layers basically. So we see a layer of inflammation, then we see a layer of sclerosis, then we see a layer of inflammation, a layer of sclerosis. So this pattern is known as a cake layer pattern, where you can see the different layers of inflammation and sclerosis in the skin. So when we go high power and try to see what the inflammation is, it's predominantly a lymphohistiocytic infiltrate. So there are lymphocytes, histiocytes, there are mixed giant cells. You can see all the giant cells here. The inflammation also has scattered plasma cells in the infiltrate. And when you look at the sclerotic areas, it is mostly sclerotic dermis. If you do an EVG stain, there might be some loss of elastic fibers there actually. There's usually no vasculitis. So this cake-layered pattern that you see here of inflammation that is composed of a lymphohistiocytic composition plus some giant cells, plasma cells associated with the sclerosis, which can even go into the subcutis, is very characteristic of Necrobiotic lipoidica. So these usually present as red, yellow, orange or brown atrophic plaques, often on the shins. They can be associated with diabetes mellitus, but every patient of diabetes is not going to develop NLD. And this pattern of inflammation that we saw here comes under the palisaded granuloma pattern actually. So when we talk about palisaded granulomas, the other diagnosis that you should always consider in the palisaded chapter is one is rheumatoid nodule. So rheumatoid nodule clinically will present as painless skin color subcutaneous nodules in patients who have which are usually located on the extensor surfaces. And when you look at a biopsy, very classically what you see is this palisaded granulomas. So palisade, the literal meaning of palisade is like either it could be considered as a necklace, that is a palisade, or the fence that you see around the house basically. So it's like a fence that you see around the house. So this palisade that you see here, this is a palisade that you see here, is around some necrotic area basically. So you can see this, it's almost like forming a ring, a fence around it actually. So that is the reason this is called a palisaded granuloma. This is also forming a fence. So this palisade is usually composed of these lymphocytes and macrophages. And whenever you see this, this is called palisaded granulomas. And when we talk about palisaded granulomas, your list of differential diagnosis includes granuloma annulare, NLD, which we talked about, the necrobiosis lipoidica. The third one is rheumatoid nodule, and the fourth one is necrobiotic xanthogranuloma. So these four will present with these palisades of palisaded granulomas. So when you see this palisaded granuloma, you know that you are dealing with either of these four diagnoses. And then you have to just go into the center of the lesion and see what do I see within the palisade basically. So in rheumatoid nodule, what we see is this completely necrotic area, very eosinophilic necrotic areas within the palisade. So this palisade is composed of macrophages, lymphocytes. In rheumatoid nodule, you might see some plasma cells. Eosinophils are usually absent. And then you see this eosinophilic necrotic fibrinoid changes within the palisade actually. And that is very characteristic of rheumatoid nodule basically. And the rheumatoid nodule tends to usually be in the lower part of the dermis. So you see this palisaded granuloma in the lower part of the dermis. Granuloma annulare usually presents with these annular lesions that are red-brown, often involving the acral sites. There are multiple different subpatterns, but this is a very classic lesion of GA. And histologically, it comes under the palisaded granuloma. So again, we're going to see that palisaded granuloma here. So in the low power, you can see this palisade forming here. Let's zoom in. So again, you see this collection of macrophages and lymphocytes forming like a palisade or a fence around collagen bundles that don't look as necrotic as we saw in the rheumatoid nodules. So here you can see that the collagen bundles are altered compared to normal collagen on the outside, but they still maintain their outlines. So this reaction pattern is known as necrobiosis. So it's not necrotic, it is not normal. Somewhere in between necrosis and normal. So this is necrobiosis. So you see this palisade of granuloma around necrobiotic collagen. And if you do a mucin stain, you're going to see increased mucin within the palisade. So you won't see increased mucin outside of the palisade, but you're going to see increased mucin within the palisade. And that is very characteristic of granuloma annulare. Granuloma annulare is a very common cutaneous manifestation that you're going to see. And histologically, it can present with either that palisaded granuloma that you saw, but there are other variants that you should be aware of. One is known as interstitial granuloma annulare, where you can see there's a lot of inflammation. So it's called the busy dermis. So this is very busy. There is a lot of action happening throughout the dermis. Vaguely, there is some palisade formation, and if you do mucin, you're going to see pools of mucin scattered throughout these infiltrates. So it won't be throughout, but pools of mucin scattered throughout the dermis. And characteristically, I remember in my training with Dr. Rapini, he used to say perivascular lymphocytes and interstitial macrophages. So if you remember that, that is a very nice feature to remember for granuloma annulare. Perivascular lymphocytes that you see here, and then the interstitial macrophages. So if you see that scattered throughout the dermis, and then if you do a mucin stain and you see pools of mucin or increased mucin forming focal areas throughout the dermis, that is very characteristic of granuloma annulare interstitial type. Another variant that you should be aware of is deep GA, because this could be misdiagnosed as a rheumatoid nodule. So because again, you're in the deeper part of the lesion, you see this palisades of granuloma that are forming around necrobiotic collagen. Here the clinico-pathological correlation is very important, because this tends to occur in children, so somewhere between 10-20 years old. And then you see this deep lesion, and this is usually on the extremities. And then when you go high power, you see this collection of macrophages forming around palisades, around necrobiotic collagen. And often you're going to see a lot of eosinophils, not a lot, but you'll see admixed eosinophils within the infiltrate. So eosinophils are commonly seen in all variants of granuloma annulare. So if you see eosinophils, that also favors granuloma annulare. So this variant of GA that is more common in young children is called deep granuloma annulare, where you see the palisade in the deeper part of the dermis, composed of macrophages, lymphocytes, and plus minus eosinophils around necrobiotic collagen. Again, if you do the mucin, it's going to be increased within the palisade. So moving on to the last differential diagnosis in the palisaded granulomas is necrobiotic xanthogranuloma. These are usually associated with monoclonal IgG kappa gammopathy, and they present with these red, brown, yellow plaques, often periorbitally, that you see here. So as the name suggests, necrobiotic xanthogranuloma, so there's going to be a lot of necrosis. There are going to be xanthomatous cells, and there are going to be granulomatous cells. So you can see there's large areas of necrosis that you see here that are surrounded by these palisaded granulomas. So you can see these large areas of necrosis throughout the dermis. So that is the necrobiotic xanthogranuloma, because if you go hyper, you're going to see xanthomatous cells, which are lipid-laden macrophages. So you can see a lot of xanthomatous cells within the infiltrate. You can see the xanthomatous cells. And then if you look around, you're almost going to see two-tone giant cells actually. So the two-tone giant cells are very characteristically seen in necrobiotic xanthogranuloma. Another characteristic feature that has been described is the presence of these cholesterol clefts within the necrotic area. So you can see all these cholesterol clefts within the necrotic area. So the giant cells, which could be either two-tone giant cells or multinucleated giant cells, cholesterol clefts large areas of necrosis that are surrounded by this palisade of lymphocytes.